Welcome to the Triage Method podcast with me, Gary McGowan, and my co-host, Mr. Patrick Farrell. Paddy, how are you this week?
I am positively splendid. I am off the back of 2 weeks of holidays. Now this podcast is actually delayed because look, I leave for 2 weeks and everything triage related just falls apart. I had some things scheduled out. I was like, yeah, cool. We have one for when I'm on holidays. It's all good. Gary, Nicola, you'll get a nice podcast recorded in the interim. 2 podcasts even will be ideal. But then, Gary, you decided that, life was a bit too easy. You were playing it on easy mode a little bit too much, and you just wanted to, kind of level up and, make things a little bit harder. So what did you do?
I decided to rip my hamstrings off the bone. So that was good.
Nice. And that's all good now. You're healed up and everything?
Yeah, I went for surgery. Yeah, I required surgery, and now I'm 3 days post-op, so I'm fairly incapacitated and will be for the next few weeks, but we're back on the path.
Fantastic. And I know you've helped a lot of people with like hamstrings, well, not hamstring surgeries in themselves, but the rehab process from like hamstring injuries and just surgeries in general. So obviously people should be following you on the Instagrams because you're going to be, documenting your stuff. But what are you looking at the timeline wise? What are you thinking your prognosis in terms of your return to play?
Yeah, so I suppose like my marker for return to sport is being able to get back to jiu-jitsu sparring as normal. I suppose that's kind of the marker. So I think probably January to March 2023, which is fairly far away, but I'd say maybe 6 months to get back to maybe showing up to training and those types of things, then another couple of months onto that for being at my full level of fitness. Because naturally, the injury itself is something that is going to weaken your muscles to some degree, because basically the mechanism is like the internal mechanism. The muscles started to tear. So I actually have like muscle tear and bruising along with the rupture. And then that force eventually ruptured the whole thing off. So there's going to be a lot of weakness. It's going to take a lot of time to regain that. And obviously my other leg is going to weaken to some degree as well. So
you get a lot of like atrophy or atrophy because you're not using it. It's the same process as someone like, oh, I'm just going to take 6 months off the gym or whatever. Like, yeah, your muscles stick around. Like it's kind of hard to lose muscle. But if you're providing absolutely no stimulus to those muscles, they go away a lot quicker than you think.
Yeah, so I'm going to be in a knee brace for the next 6 weeks, and I'm going to have hamstring atrophy, I'm going to have glute atrophy, I'm going to have calf, quad, bone atrophy, because that leg is going to be non-weight bearing. So there's going to be a long enough rehab process there. But thankfully, I probably couldn't be in a better position compared to other people in this type of injury, because, I'm familiar with the rehab process. I've helped others through the rehab process. We have Luke on the team, who's another physio that I can bounce ideas off. I obviously know a lot about exercise, I like to think. So I should be in a good position to make a good stab at the rehab, but we'll see how the next few months go.
Fantastic. Anyway, that was just a quick life update. Let's get cracking with the actual episode, because this episode is it's probably going to be quite fact heavy, I suppose you'd say. But it does answer a lot of, well, hopefully at least it answers a lot of questions that people have, because we're going to discuss exogenous hormones, right? We've been doing this female series. We've been doing all the stuff related to, the potential differences in women's and men's health, and the potential differences in how you train or do your nutrition or whatever. But there's always a question in there, and you're like, oh, well, what about exogenous hormones, right? Like if you say exogenous hormones and you're talking about a man, everyone all thinks that, oh man, we're talking about steroids here. We're talking about, getting absolutely jacked out of your mind, right? But when we're talking about exogenous hormones for women, generally we're talking about some sort of contraceptive, right? Because that's been the whole, I suppose, story for exogenous hormones for women, at least up until menopause, right? It's very infrequent that you'd see someone go on exogenous hormones in just their normal average everyday life until hormones start to decline. It might be a little bit more frequent for men that they go on exogenous hormones because people do steroids. You go to the gym, like I'd say maybe 25% of the men in the gym are on steroids. Depending on where you live, probably more. Like if you live in a port city, it's probably 50%, because there's ease of access to drugs. That's why you also always see like really good gyms popping up in port cities. It's because there's steroids coming in. But anyway, that's an aside. But for women, it is a little bit different when we talk about exogenous hormones. We're usually talking about contraceptives, or they're using exogenous hormones to induce an environment that is not conducive to having children, right? So let's talk about that a little bit more. We'll start with the kind of obvious ones here, the oral contraceptives. And I don't think we need to do a huge, big, like comparative podcast on like all the different types of contraceptives and whatever. But effectively, the first question I want to introduce with this is, are there better or worse oral contraceptives? We'll stick to the oral ones. Like obviously there are other ones as well, but we'll just say oral is the main focus. Are there better or worse ones?
Yeah, so we will focus on the oral contraceptive pills today because I think that's what people are most frequently going to be coming across. And there's kind of other unique concerns when it comes to intrauterine devices and things like that. So let's stick with the oral contraceptives for now. And the question is, are there better or worse options? And of course, the answer is yes. There's not just one option. There are multiple different options. And what I'd like to do is walk through some of the differences between different types of pills and give you an idea of where you're at today in terms of like when you start the combined oral contraceptive pill, what should you expect? How does it work? What are the side effects, etc.? So looking back or taking a kind of a broad picture first, when you look at the pills themselves, you can get combined oral contraceptive pills or progestin only pills. Generally, it's the combined oral contraceptive pills that people are going to be taking. And then the other options are things like
Sorry, just on that, what does combined mean?
So combined oral contraceptive basically means that you've got a source of progesterone and estrogen. Okay, so it might be something like ethinyl estradiol, and your progestin could be multiple different types. And I'll go through the generations of those in a moment. So when we say combined, we're talking about estrogen and progesterone versus progesterone only or progestin only pills. Okay, so
just on that as well, again, it just makes sense to think back to the normal quote unquote menstrual cycle. Like we basically have a balance between estrogen and progesterone at different phases of the cycle, or stages I should say of the cycle, that they're going to be in different relative ratios. So again, you'd be thinking, okay, those two are the quote unquote female hormones, so we're basically supplying them.
Yeah, and then you have the generations of the pill, or the generation of the progestins more specifically, which differentiate the different types of contraceptive pill over time. So I think the oral contraceptive pill was first introduced in the 50s, and I think improved then in the 60s, in line with the sexual revolution in the US and all that. So it was a good period of time for sexual liberation, if you will. But it's really important to note that is a relatively novel introduction to human life, that we suddenly have this ability to be more selective, that a woman can, go out into the workplace with menstrual products, in the preceding decades, and then also can now, partake in sexual intercourse with contraception. So there's not that, risk of getting pregnant. So that's a big introduction to human society. So
it's often, they say like, it's almost like one of those industrial revolutions, like it's a revolution in society, basically being able to be in control of your own reproductive health. And like you kind of forget about it because obviously the internet came about 30 years later than all of this, and it's kind of overshadowed just how much of an impact being in control of your own reproductive health has had on society. Like so much has changed as a result of effectively, again, being in control of your reproductive health. And it is one of those real paradigm shifting things, and it's only when you really start to think about it do you realize just how transformative being able to control your reproductive health actually is to society. Like you are now actually able to be a way more present person in society. And what I mean by that is you're actually able to engage in so much more of what society has to offer because you are in more control of your reproductive health. Now obviously it doesn't solve even all of society's ills, it doesn't solve all of society's issues, but it is a transformative event for women. well, men as well, for society in general.
It certainly is. And since that period of time, there have been multiple different generations of pill, as I've said, or of progestin specifically. So early on, the first generation and second generation progestins would have had a lot more side effects associated with them. And a lot of the time when people read about the pill, they end up reading information that applies to those early generation pills, but not necessarily to the later generation pills. So it's important to be clear about what pill you're talking about when you're reading about side effects. So the third and fourth generation progestins, which would be things like norgestimate, which would be third generation, and then the fourth generation is drospirenone. The thing that's interesting about these is that these tend to exhibit fewer side effects, first and foremost, and also less androgenicity. Okay, so the pill can have some androgenic effects. The progesterone in particular can have androgenic effects. These progesterones are derived, or most of the progestins at least, are derived from testosterone. But these later generation progestins seem to be less androgenic. So that's something that is important.
Some of them even have like anti-androgenic effects, and you always have to go back to like looking at either, like, you know, if you want to call it the organic chemistry, the biochemistry of it. Like all of these hormones, well, not all of them, but a lot of these hormones, they have this kind of like cholesterol, we'll say, kind of backbone, and then they just have modifications from that, you know. And the progestins here, they're basically derived from testosterone. So you get cholesterol here, you do all the modifications to get it to testosterone, and then you do a few more modifications to that, and you've got these different progestins, right? So they're still similar enough to testosterone, you know, that potentially they have androgenic effects, especially like the first and second generation. They might have had more androgenic effects, but then when we actually get some more modifications, you might actually still get binding to, say, the testosterone receptor, or I should say the androgen receptor, and you actually just don't get signaling as a result of that. You might get some signaling, but it actually isn't the same signaling as if testosterone had bound to that androgen receptor, you know? So it's very interesting to look at it in terms of the biomolecular pathways that occur. And this is also why people use like different steroids in like, you know, bodybuilding and stuff. They're like, right, well, they have different binding affinity to the androgen receptor, or they have different effects once they do bind to that androgen receptor. And this is kind of similar here when we're talking about the different progestins, especially the fourth generation progestins. They have somewhat anti-androgenic effects, which again is potentially beneficial for a lot of women, especially if you are dealing with something that potentially, you know, has an excess of androgenic signaling. Like maybe you're dealing with PCOS, for example. You might be like, right, I actually want to go on one of these fourth generation, for example, oral contraceptives, because I'm getting some sort of anti-androgenic effect along with, you know, the other stuff that comes along with an oral contraceptive.
Yes, sir. And to kind of put that in maybe a real world example for people, Yasmin is one of the pills that a lot of people would be familiar with, and that actually includes one of the fourth generation progestins. So it's a combination, to my knowledge, of ethinyl estradiol and drospirenone, which is a fourth generation progestin. So that would be one of the newer pills on the market. Now, I don't know all the brand names. It's one of the really difficult things about translating medical knowledge over to practice, is that all these different brand names, especially then when you move between countries and everything. But that's a common enough one that people.
Yeah, like when we do, like we have a new client coming to us, we might ask them like, oh, what, like, you know, medications are you on? Or like when we're talking about their overall like menstrual health in general, or their, you know, reproductive health, like, okay, well, what oral contraceptives are you using, or what's the story there? And sometimes you're getting these random, like, because obviously we work with people all across the world, like sometimes you're getting these random names and you're like, trying to look it up, being like, what brand is this? What is this? What's going on here? What's the story? There's so many different ones. That's why we're not going to get into different brands and different types here today. But it is important to know that there are differences, right? So you might go to your doctor, they might go, yeah, you're on this different pill here, and you might try that, and it might not be effective for you. It might not be the one for you, because again, there's differences in terms of the types of progestins used. A lot of them usually use ethyl estradiol nowadays. That's usually the one that's most common, the estrogen that's most commonly used, but then they'll vary the different types of progestin that is used, right? So that's one difference, but also you can then have differences in terms of the quantity of the estrogen versus the progestin, you know? So there's differences there. Some people do better with a higher estrogen to progesterone load. Some people do better with the like vice versa of that. Some people do better with a more even. And again, that's a very individualized thing. So unfortunately, there is actually guidelines for this. You could find them online. Like people have like these little flow charts and stuff being like, if you try this one, this is your first line intervention. If you got these side effects, do this, blah, blah, blah. You can find those kind of flow charts online. And I know like doctors obviously use something similar to that. But it is important to know that while we're talking in like broad strokes here, there are still differences. So when we're talking about like answering the question here of like, are there better or worse oral contraceptives? You have to look at this as the broad, generalized thing. And then you have to go, okay, well, how does my body actually react to all of this stuff? Because at the end of the day, look, I'm not a doctor. Gary's a trainee doctor. Nicola is a doctor, but she's not here with us today. She's on holidays, and she couldn't make it. So that is important to understand. I'm an idiot. Gary is clearly an idiot after ripping his hamstring off the bone. So take our advice, or not even our advice, take our information with a grain of salt here.
Yeah, I can confirm also that everything I think we're going to say in this podcast has been signed off by Nicola in advance as well. So
definitely not everything, because I'm an idiot.
Our notes at least. But yeah, anyway, so as Fatty said, look, there are variations in dosing in terms of like the absolute quantity of each respective drug within a combination drug, but there are also variants in terms of how that drug is dosed across the cycle. So for example, there are combined oral contraceptives that are referred to as multiphasic, and the goal here is intended to kind of match the fluctuations in hormones across the normal cycle, and that would be in comparison or in contrast to a monophasic pill, which would basically give you the same dose throughout. And there doesn't seem to be any advantage for the multiphasic option, really. So monophasic is fine. It can just be a consistent dose during the dosing period. And then the second part of that equation is, the so-called off phase. So for example, a lot of pills will use a 21/7 setup where you take the pill for 21 days, and then there might be, empty pills for the 7 days, or you just don't take anything for 7 days. And that's basically giving you nothing or no ovarian hormones during that period of time, with the intent of allowing for a withdrawal bleed then during that period of time. There are also 24/4 preparations, and it seems like that leads to better suppression of ovarian follicular activity, which would be good for efficacy of contraception, and may also reduce symptoms associated with hormone withdrawal. So for example, the mood symptoms, the headache or pelvic pain that might be experienced during that time, that seems like they might be reduced on the 24/4 preparations. And then finally, I suppose like one thing to note is, why not just take it consistently? Why have these off days at all? And that seems to be something that people are moving towards more and more over time, because it seems like that the withdrawal bleed may not actually be medically necessary, even though it was thought to be previously, and that the suppression continuously is safe. One thing about that, though, is that you can get some unpredictable bleeding or spotting events at different stages during the cycle, as opposed to just having that withdrawal bleed when you stop the pill. So continuous cycle is becoming more popular, but overall, it's not like there's huge differences here between the off days or not off days. But a consideration there would be things like adherence, for example. That might be a consideration for people. What symptoms do you experience during those off days? If it's a case that you're taking the pill and then not taking anything for a few days, are you restarting at the appropriate time? All these types of considerations to be discussed with your doctor, really, when it comes to prescribing a specific pill, but that at least gives you some idea as to the different preparations that are available and the different dosing schedules that are available as well.
I don't know how accurate this information is, but I've heard it from multiple sources. And according to the information that I've heard, originally they did plan on using the pill for like continuous. That was the initial, like, right, here you go, just take this pill continuously. It's going to provide contraceptive benefits as a result of that, But the women in the studies were like, well, I want to actually know that I'm not pregnant. You know, obviously this is at the initial point, you know, they'd never been tested, wide scale. Like obviously they had been tested, but they'd never been tested wide scale. So people didn't have a huge amount of belief in the efficacy of them. So they were like, well, I want to have a period because I then at least know that I didn't get pregnant, you know? And so that was one of the reasons that they did bring in that, like, oh, here's 21/7, you know, obviously, you know, to match the quote unquote normal cycle as well. But it gave the women a feedback moment of going, okay, you're not actually pregnant. This is actually working as a contraceptive. Now, I don't know how accurate that information is, but it is important to understand that these were effectively designed to be taken continuously, you know? So it's not necessarily a bad thing. Now, there are potentially some negatives down the line when you do eventually come off it. Like I know a lot of people take oral contraceptives for, say, PCOS. You know, they're just like, right, I'm always on it because I don't, like, they have really bad symptoms of their PCOS if they're not taking the pill continuously, right? And then when they come off the pill, like maybe they want to get pregnant or, you know, for whatever reason, like they do tend to have, in my experience, worse symptoms, but it's hard to tell. Is that just the fact that like you've grown accustomed to having no symptoms, well, not no symptoms, but reduced symptoms from your PCOS, or is it the fact that you've been on exogenous hormones for X amount of time? You know, and we have to remember that female physiology is different than male physiology, because if you're a male and you take exogenous hormones for an extended period of time, like you're probably going to get some, you know, atrophy of your testicles. That's probably going to be a very common thing. You know, you're going to see that in the first, like, whatever, couple of weeks, even if you're on exogenous hormones, right? But that can cause issues with your actual testicular function as a result of that. Like you can get scarring on the testicles, you can get, you know, a reduction in the efficacy of your ability to produce sperm and different things like that, or even produce testosterone in the future, right? But it doesn't seem to be the case with women. You know, you don't seem to see those same issues. Now, there's potential reasons for that. For example, like the testicles are used to bathing in, like, what is it, like 10 times the amount of testosterone, 100 times the amount, I can't even remember the figure, but way in excess the amount of testosterone that the other cells in your body get. So they're used to that, and that's the signaling that they require. Whereas if you're providing exogenous testosterone, it's not like, oh, it's going to go straight to my testicles, you know? So they don't get that same you know, signaling that they require, right? Whereas that's not really the same way that the ovaries work. You know, it's not really the same way that the female physiology works. So there's less of a concern, at least to my knowledge, with more continuous use of oral contraceptives. You know, that's not to say that you as an individual won't experience like issues if you're on the pill for whatever 20 years and then you decide to come off. Like, you know, post-pill depression is very common. You know, some people will say that you have an increased risk of infertility if you've been on the pill for an increased amount of time, but it's hard to tell. Like, you could just be someone that would have naturally got to a stage where, you know, you're at 35 and you're almost going through a reduced fertility period anyway, you know, and now you're just like, well, I've been on the pill for the last 20 years. Is it the fact that you're 35 now, or is it the fact that you've been on the pill for 20 years? You know, it's hard to disentangle those two things.
Yeah, and I think the best attempts to try to disentangle it seem to kind of result in the conclusion that being on the pill doesn't reduce your fertility when you come back on. And there's even some evidence of long-term use where your fertility is maybe a little bit better, but I wouldn't hang my hat on that really. It just seems like there's probably not much of an effect on your chance of conception after coming off it. So a lot of women do have concerns about that. They're worried that, you know, by shutting down their ovarian function for a certain period of time that it mightn't return, but it doesn't seem like that's actually supported by the evidence. So that's hopefully of comfort. But there's plenty of guidelines out there on that if you'd like to refer to more reliable information. The American and Royal Colleges of Gynecology have lots of information on that, so you can check that out. But one question that you might be thinking now is, you know, how does the pill work? You know, and that's a good question. And the answer to this is in relation to the release of, firstly, hypothalamic hormones, and then pituitary hormones, and then ovarian hormones. Okay, so it's all to do with this axis of hormonal physiology. So you get the suppression of ovulation, which is obviously the end target, where we don't want to be releasing an ovum for fertilization. And this occurs by inhibiting the release of GnRH. So this is gonadotropin.
Just say, just on that, you basically, when you're born, you have all of these immature eggs, right? They're stored, and then they mature across your lifestyle, can't even speak, across your lifetime, after effectively reproductive age. Once you're at that kind of teen time, when you start hitting that menarche, that's when they really start to mature. But you're basically born with all the eggs that you're going to have, right? And then they mature over time because of these hormones that Gary will talk about in a second. But it's also a little bit interesting to kind of think about that, being that it was actually your mother who made those eggs. This is why, again, if you look at generational issues, like say people do like studies on the Dutch famine, for example, in Nazi occupation, all that kind of stuff, right? You see effects for like 3 generations, and it's because your mother made the eggs that you have. Now obviously, look, it's your cells. That's effectively the way it is. But those initial like immature eggs were made by or in your mother's body, like obviously in her womb when you were developing. So her nutrition and her epigenetic signature, all the stuff that was going on in her life, those actually influence her grandchildren as a result of that. So it's important to understand that, like, even though we think of ourselves as completely individual, it's only my lifestyle choices that matter, blah, blah, blah. Like, it is multi-generational, at least for 3 generations, that you're going to see effects from what you do or what your mother did or what your grandmother did. Like it goes across generations like that. So it's important to understand, right, we have these immature eggs, they're in your body for your life. And then when you reach menarche, they start to develop. And why do they develop? Well, there's a few different hormones that Gary's going to talk about.
Yeah, so as I said, GnRH, or gonadotropin releasing hormone, that's like, there's a lot to be learned from the name of hormones in endocrinology. And what you've got there is gonadotropin releasing hormone. Okay, so what that means is that it's the hormone that's responsible for releasing the gonadotropin. So effectively what happens is that signals to the pituitary, which releases LH and FSH, which are luteinizing hormone and follicle stimulating hormone, both of which play a key role then in acting on the ovaries to permit ovulation, to permit the subsequent processes of conception, of development, etc. Okay, so it all goes downstream from there depending on what direction we're going in. So is there a normal menstrual cycle? Has pregnancy taken place, etc. Okay,
and again, if you go back to that, like you see those menstrual cycle like hormones pictures, like again, I think we posted one previously anyway, that you can see the different hormones at the different stages of your cycle, and you'll see LH and FSH. You'd be like, that mid-cycle point where you're ovulating, all of a sudden they surge, they go really high. So again, you see it all interplay.
Yeah, so that LH surge that occurs in the middle of the cycle, that's the point at which ovulation occurs. So without that, ovulation doesn't occur, and that's suppressed then as a result through this process. Okay, so you get GnRH is inhibited. This suppresses the release of LH and FSH, and that suppresses the process of ovulation. Okay, we also get suppression of other things related to fertilization, related to the reproductive process. So, for example, the endometrial lining of the uterus, this gets atrophied, and also we get thickened cervical mucus. So this stops basically the passage of sperm. You can imagine it's much more difficult for sperm to swim through a very thick medium than it is through a thinner medium. Okay, so all of these changes as a result of the contraceptive pill are what lead to that contraceptive effect. Now, with that said, does that mean it's 100% all of the time? No. Okay, no contraceptive method really is 100%, other than total abstinence, of course. Perfect use of a contraceptive pill, the combined oral contraceptive pill, tends to lead to 99.7% effectiveness, okay, or efficacy. So if everything's going 100%, you're using it perfectly, you never vomit, you never miss a dose, everything's spot on, 99.7%. Typical use, i.e. the way that most women are going to be using it when it's observed in studies with women on the pill, seems to be about 93% effective, which is pretty good. And for comparison, the pull-out or withdrawal method, which many people use, is only 80% effective. So you think about that, that's a 1 in 5 chance of pregnancy using that method. So not very effective, to be honest. And I think a lot of people would reconsider if they knew that there was a 1 in 5 chance. And then condoms, 87%. Okay, and again, these are typically used. So as the pull-out method and as the condom method are typically used, they're the percentages that you're looking at. And then with all the other contraceptive methods that we mentioned previously, but aren't going to go into in detail, they tend to be around or below the level of the contraceptive pill. They're all in that range of kind of 90+% generally, depending on the method. Obviously, if you're looking at things like more permanent sterilization methods like vasectomy, you're obviously going to be looking at higher percentages, but for the most part, that's what you can expect if you're on the pill. Okay. Now, another question and another thing that's really important to discuss in relation to the pill, and this would be something that your doctor would discuss with you, are contraindications. Okay. So there are certain conditions, certain lifestyle factors, etc., that would make the combined oral contraceptive pill a little bit less appropriate for someone. Okay. So some of those would be older than 35 years, or if you're a smoker. A lot of this has to do with the risk of venous thromboembolism. So this basically means that you get a clot. The estrogen in the pill does increase the risk of blood clots. It's still a relatively low overall absolute risk, but it does increase the relative risk. So any factor that would increase your chance of getting a clot would be a potential contraindication for taking the pill. If you have multiple risk factors for cardiovascular disease like age, smoking, diabetes, hypertension, if you've had a previous venous thromboembolism, if you've got established heart disease or previous stroke, breast cancer, migraine with aura is another one. The aura basically just describes that kind of visual experience people have when they have migraines, liver cirrhosis, and diabetes with complications like nephropathy, i.e. kidney damage. So all these things would be potential contraindications for someone taking the combined oral contraceptive pill. And most of these things, they're likely that you'd be aware of them already. If you've got heart disease and if you've had a stroke or you've had breast cancer, generally you're going to be a bit more careful about what medications you take anyway. So hopefully you're discussing that with your doctor. But it is important because there is an increased risk of blood clots. Obviously, when you're taking exogenous hormones and you're talking about things like breast cancer, that's an important consideration because certain cancers are hormonally related or hormonally sensitive. So you want to be careful about exogenous hormones that you're taking. And then cardiovascular disease, I mentioned a few times there as well. There is an increased risk of cardiovascular disease. It's still a relatively low absolute risk, but you do get some slight increases in risk when you're on the pill. So that's something that's important to be aware of. Okay.
Yeah, and with those as well, especially for like blood clots and stuff, like it just pays to first of all read the insert in your medication, because your doctor might not have covered this stuff with you. It might have been like, oh yeah, just go on this, because they see a relatively low risk with this stuff, and they might be like, it's fine, it's grand. But you might personally think that risk is too much for you, or you might have forgotten to mention a family history of whatever, a certain risk factor. So it does pay to actually, read the insert, but then also just become aware of the different symptoms that you might experience. Like, say, for example, I know a good few women that have had blood clots as a result of the pill. Usually it happens in the legs. They'll find they have a blood clot in the leg. So just becoming aware of the symptoms of that, becoming aware of okay, well, what does a blood clot in the leg feel like? What does it look like? Etc. And what do you do then after that? If you're on any medication, you should be aware of first of all, the counterindications to taking that medication, but then also the potential ramifications of taking that medication. Nothing is risk-free in the medical world, and there's always, in the world in general, nothing is risk-free. You just have to be aware of the risks. It's a personal thing. Obviously your doctor has your best interest at heart, you would hope, but ultimately they might not have the same risk aversion that you have, so you have to weigh up this stuff on an individual basis for yourself.
Yeah, and most of the side effects associated with the pill are going to be relatively mild. Things like breast tenderness, nausea, bloating. Some women might notice changes in their mood and things like that. the symptoms tend to settle. Like if you get bloating, for example, or you feel a bit nauseous, it might settle down. But sometimes people might try different pills or different contraceptive options. So that's something you work with your doctor on. But as we said, I suppose the three big ones that people often consider in relation to the pill are the blood clots, which, as Paddy said, typically going to get them in the legs. Deep venous thrombosis, DVT, often manifests as like you get redness or tenderness in your calf. But unless you've got other risk factors, it's generally not something that you need to be like really worried about. But it does increase the risk. There is also an increased risk with pregnancy and in the postpartum period as well. So I mean, if you were to get pregnant as an alternative to taking the pill, like you're still exposed to the risk and a higher risk, unfortunately. And then cardiovascular disease, as I said, it's not a very large concern, but again, there is an increase in risk and potentially small increase in blood pressure as well. A lot of women tend to have, lower blood pressure than men on average, but it's still a consideration to keep in mind for sure. The cancer is a little bit of a messy one because there's kind of conflicting evidence on breast cancer, and there's different types of breast cancer. Depends on the specific receptors that are involved in the breast cancer, whether or not they're hormone sensitive and to which hormones. And then cervical cancer, ovarian and endometrial cancer are other things you might be concerned about. It seems like there might be a slight increase in cervical cancer, but a reduced risk of ovarian and endometrial cancer. Okay, so the risks in relation to the decision-making process of any medication always involves balancing the pros and cons. So that's why we recommend taking your specific case, discussing it with your doctor, and then they can help guide you based on your past medical history, your current medical state, and the reasons for taking a medication, and then you can start to make an informed decision that way. Okay. Now, one final note there on that is just that it's not just about contraception. It's an important note. Although, they're called the contraceptive pills, they are exogenous hormones. And that's why we've used that phrase multiple times. And there are certain cases where someone might be prescribed a combined oral contraceptive pill for reasons other than just contraception. So for example, as we've actually discussed in multiple of the previous podcasts, things like, for example, pelvic pain related to endometriosis, pain associated with periods, heavy periods that are leading to lots of blood loss, all those different features of menstrual cycle pathology, I guess you could say, they can all potentially be managed through the combined oral contraceptive pill. So that there are some indications. Other things would be things like use in PCOS to regulate the menstrual cycle potentially. They can be used to reduce risk of ectopic pregnancy. All these different things that are potentially other effects of the combined oral contraceptive pill. Okay, so there's lots more in there, lots more that you could go through in terms of the effects on mood, and PMS, PMDD, what else is there, cancer risks, acne, etc. Lots of different effects, obviously, of any exogenous hormone. So it does go beyond just the contraceptive effect.
Yeah, so Gary, what's the best pill to take?
Whatever one your doctor tells you to take. That's my diplomatic answer. But look, in all seriousness, like the estrogen forms are generally going to be pretty consistent. It's often the progestins that people will kind of play around with. So, the newer generation, third and fourth generation progestins, the combined OCP with, for example, like the Yasmin pill, where you've got ethinyl estradiol and drospirenone, tend to be relatively well tolerated, tend to be efficacious. So those newer generation pills, they seem to be effective for the outcome that you're desiring, while also minimizing the side effects. But again, the specific pill that may be effective or maybe best for you might depend on the specific indication and your overall medical history and symptoms experience. So that's my diplomatic answer.
Yeah, and I'm going to only add to that and say that if one pill doesn't work for you, there are other options. As I said, you can find these flowcharts online. Maybe that's not the best place to find them. You can talk to your doctor about this stuff. You can be like, right, this one, I'm getting these side effects. Is there something that we can do to mitigate this? Whatever, but I just want to reiterate that you don't have to just stick to the first one that you're given. You can be like, right, this one's having these negative side effects that I don't like, or I'm feeling X, Y, and Z. you can change it. Because you often find that people do stuff like they'll just take, the pill that their doctor prescribes, or like, yeah, take this one, and they won't keep track of like symptoms. And then they realize like 5 years later, 10 years later, that they've been having like, I don't know, depression since they've taken, like they'll be like, this is actually a fairly serious side effect, but because you weren't paying attention to it, because you were just like, blindly trusting your doctor, you won't realize that. But there are other options. So it pays to pay attention to how your body changes, how your body reacts to whatever medications you take, whatever changes you make to your diet, lifestyle, and then come up with a plan of action going forward with that. Like some of those side effects, you might be like, you know what, that's fine. It doesn't impact me massively. I'm fine with that occurring. Some of the other ones you might be like, that's actually not what I want to have occur. Like you might notice that your entire personality changes. Like there are other changes that occur that we haven't even touched on, as a result of like, you're basically playing with your hormones. Like they often say that there's things that go along that are like, it's weird in terms of how much it actually impacts your life. Like people do stuff like they'll meet a partner when they're on the pill, and then when they go off the pill, they actually won't be as attracted to their partner anymore, because they're basically in a different hormonal environment as a result of being on the pill. And like that kind of stuff, whenever I read that, I'm like, this is like so far reaching, like into your life. Like it's your partner, it's the person that you've ideally chosen for the rest of your life, and all of a sudden the medication that you're on is changing your desire towards them, or the medication that you're now no longer on is changing your desire towards them. So that kind of stuff has far reaching impacts. And again, you just have to be aware of that stuff going forward, because I'm sure there's many people out there that got married, they're on the pill, and then they're like, all right, let's have children, and then they come off the pill, and all of a sudden they're like, you know what, I actually don't find this guy attractive anymore. So that kind of stuff, it's important to understand that it does have far-reaching implications, psychological health especially, but just in terms of your actual interaction with the world as well. But again, there's flowcharts online. You can look it up and you can go, okay, I'm having these side effects. What's the next option? Go into your doctor informed, give them your side effect profile. Now, the hard thing about this is everyone, as soon as they start looking at side effects, they start going, oh yeah, I have that. Oh yeah, I have that. They become like a hypochondriac and going, yeah, look, I have all of those things and they're the worst that anyone has ever experienced them. So you kind of have to trust your doctor to some extent. But again, you also have to be your best advocate. You're the only advocate for yourself and go, I'm actually having these side effects that I don't like, So there is that little bit of a balance there. Do you have anything else to add on that, Gary?
No, I don't think so. I think the next question that's important is, right, all this talk about all these facts and, pills and doses and hormones, what does that mean for your training? There's kind of two key areas here. One is performance and one is body composition. That's the reason most of you listen to this podcast. So does the pill impact your performance?
And let's just set the scene here, right? If you go online and you look up this stuff, right, you're going to be hit with, oh man, you take exogenous hormones as a woman, your performance is going to be shit. Your body composition is going to be shit. But if you take exogenous hormones as a man, bro, your performance is going to be fantastic. Your body composition, best it's ever been, So is that fact? Is that just the way it is, Gary? Because if you go on any social media, you do a quick casual Google search or whatever, you're going to come away with that general overview. That, oh, here, take exogenous hormones as a woman, bad. Take exogenous hormones as a man, good. But is that true?
Thankfully, it's not. Okay, so for the most part, when you look at the kind of average outcomes in the studies that have been done, it doesn't seem like there's a very significant effect on performance in either direction. There is some variation. So, for example, some users will experience a decline in performance while on the combined oral contraceptive pill, but this isn't a consistent finding, and it's not a very big effect either from what we can tell. Now, more research would be ideal here on different pill types, different responders, etc. But overall, from my interpretation of the evidence, if I was to start a combined oral contraceptive pill, my assumption would be that nothing will change. my assumption will be that my performance will continue as it was. Okay. Now, in some cases, it might be a net benefit. And an example of that would be, let's say before you had really bad PMS symptoms and you had really heavy periods, and now that you're on the pill, you're no longer having those side effects. You might be able to have more productive training during those periods of time. On the other hand, if you start the pill and suddenly you start having, other side effects, like, I don't know, maybe it impacts your mood or it impacts your motivation, or you're getting lots of cramping or bloating or something along those lines, and that might compromise your ability to engage in training. So it depends on your own individual response. And as Paddy noted previously, you don't have to stick with the first pill that you take. So if you want to, make a change to see if that has an effect on your performance because of side effects that you're experiencing, then that is something that's on the cards. But overall, I wouldn't be very confident in saying that, the pill has a specific benefit or harm from a performance perspective, because it just doesn't seem like there's much of an effect in the studies that have been done. It also doesn't seem like there's much of a difference on pill versus pill-free days, which again is something that people might be of interest or might be interested in. If they're coming up to a really hard training session, they know it's coming and it's a pill-free day, they want to know, is this going to affect my performance? And for the most part, it doesn't seem like there's much of an effect. It also doesn't seem like there's much of an effect on the outcomes from training. So for example, how you adapt to resistance training. Again, there's not that much evidence, but the muscle building or the strength outcomes, it doesn't seem like there's much of an effect of the pill on that. So again, you don't have to worry about it. Again, the effects will depend on the pill being used. There will be some variation, but it's you can't give a generalized recommendation here. There's no generalized one-size-fits-all summary of how the pill impacts exercise performance, because it's both pill and individual specific. So that's a really important thing to take away from this. And then finally, one thing to note here again is that if you are concerned about a potential negative effect, just consider as well that pregnancy will also affect performance a lot more, and so would heavy painful periods or PMS or other indications for taking the pill. So if it's the case that you're taking the pill to offset another negative experience for you, such as painful periods or PMS, which might impact performance, then the pill could be of benefit. So again, it's individual, and it's really hard to say whether or not it's going to be a positive or negative for you.
Yeah, and this is the thing as well. When you look at studies, they're looking at a population. So they can say, oh, yeah, like on the whole, on the average, seems to have no effect. But you have to look at that as with your own lens. You have to look at that and go, well, how did it affect me? You might have, again, gone on a pill or gone on an oral contraceptive and gone, you know what, actually my strength is declining. I'm doing the same things. My stress is the same. My sleep is the same. My training is relatively similar, but I'm not getting the results that I expect from this. You might conclude that, okay, for you, that pill is not the one that you should be using, but you still have other options. If you want to be on an oral contraceptive, again, you have other options. And obviously we haven't touched on it in this episode, but there are also other options for contraceptives in general. You don't have to be on, again, a hormonal oral contraceptive pill, So that's something to bear in mind. But it is also important to bear in mind that going on the pill can also be a mask for other things going on in your life. For example, a lot of people will go on the pill because they've had menstrual cycle irregularities as a result of having like amenorrhea because they're overtraining. They have that like red S or, that female athlete triad syndrome, so that's something to be aware of, that when you're talking to other individuals and you're talking about their experience about this stuff, you have to take into account what else they have going on. Because I would probably argue that it is a benefit to be on the pill if you are dealing with red S or different things like that, purely because you're at least getting some sort of estrogen signaling for bone health and stuff like that. But the unfortunate thing is it tends to mask the issue, and then people start having negative performance outcomes because they're in a net negative energy balance almost all the time. They don't have that free energy available to actually be anabolic to actually get the adaptations from their training. And yeah, okay, they're still having a period, like they're having, you know, a bleed each month because they're on the pill, but it's not actually providing all the signaling that they need because they're undernourished, they're underfueled for their sport, for their activity level. So that is an important add-on to this. You really have to look at the broader spectrum with the stuff. And just because you're having a regular quote unquote cycle because you're on the pill doesn't mean that you're doing everything right in terms of actually fueling yourself and actually fueling your training. So that has to be taken account of, because I couldn't tell you the amount of people that have come to me and said, oh, I was on the pill and, you know, I had issues in terms of my performance went down and all this different stuff. And then I asked them what was going on in their life, and it almost always along coincides with a period of time where they were under fueling, over exercising, and doing all these things, you know. So we have to take the totality into account when we're looking at the actual experience. And in my experience coaching women, I have seen huge variations in their individual response to different oral contraceptives. Some people, they're like, right, my performance is absolutely fucking trash because of this, you know. It's gone completely in the shitter. I can't do anything with this. I've had other people that, you know, they're on the pill, they're on a different pill, they're on whatever, no effect, you know. And if you are noticing effects or side effects and you're noticing your performance is declining, then again, you have other options with different types of pills. They might be more beneficial to you. It is important to note that regardless of the type of oral contraceptive that you go on, like, you are effectively giving this negative feedback loop. So you are going to have a reduction in like androgenic signaling, you know, and that might be a benefit for some populations. Again, if you have PCOS and you're on the pill to effectively reduce androgenic signaling, that could be a net positive for you, you know. Whereas you as an individual like yourself, you might have noticed that, oh, I actually have a little bit higher androgenic signaling, but it's actually good because I really enjoy sports. I really enjoy, you know, strength training or whatever, and I get really good results because of that increased androgenic signaling, increased androgen levels. And then you go on a pill and you've effectively lost that superpower, or you've reduced that superpower that you once had, you know. So again, we have to look at this in terms of not only the, you know, mechanistic stuff, but also, again, the totality of what the individual is actually dealing with. And unfortunately, that is an individual thing. You have to do that on an individual basis. Well, we can say, yeah, like, you're not going to see a massive decline in performance on the average. You know, you might actually see an increase in performance over time because you don't have to deal with, you know, PMS, you don't have to deal with XYZ, all these other things that you might have had to deal with if you didn't have the option of the oral contraceptive pill. But as an individual, I can't do that analysis for you unless obviously like I'm coaching you or whatever. You have to do that analysis on your own, you know?
Yes, sir. And the final element is, what's the effect on body composition? And again, this is an area that a lot of people worry about. They worry that the pill is going to cause weight gain. And some of this stems from, you know, the effects of some of the earlier generation progestins, which were potentially worse for this problem. And there are some types of contraception, such as the Depo-Provera injection, which is a more common cause of weight gain, and that is demonstrated in research as well. But overall, the combined oral contraceptive pills, as people take them today, have no direct mechanism that would cause fat gain as such. It may lead to an increase in caloric intake if you note that it impacts your appetite. It doesn't seem like on average that is the case, but, you know, some women might experience that. A lot of women experience changes in appetite during their menstrual cycle as it is, and often coming up to or during their periods. So the pill might even lead to better appetite management. It just depends on the individual. But overall, it doesn't seem like there's a contribution to increased fat gain. When it's been studied, it doesn't look like women starting the pill start to gain more body fat or anything like that, or that it would compromise your ability to lose body fat. With that said, sometimes you can get an increase in weight as a result of bloating or fluid retention. Again, as I said, that's generally worse with the earlier generation pills, and we tend to see reduced fluid retention and bloating with those fourth generation progestins like the drospirenone that we mentioned previously. So in summary, there may be effects on fluid balance depending on the pill that's used. There may be effects on bloating or abdominal distension, but overall, it doesn't seem like there's any real mechanism outside of some of the older generation pills and the Depo-Provera injection that would actually contribute to body fat gain or difficulty losing body fat.
Yeah, and again, in my experience coaching women, I don't see any real effect with this. Again, some women, they do change pill and then they notice a period of time where, maybe they have mood disturbances, they might have, again, we'll call them lifestyle disturbances, like things go on in their life as a result of changing the pill. Like, again, maybe they don't sleep as well, maybe they, appetite changes, different things like that. So that would be an indirect way that it causes weight gain. But in terms of mechanistically, there's no like, oh, estrogen is going to cause you to gain copious amounts of body fat, progestins are going to cause you to gain copious amounts of body fat. Like, that's not the case. However, again, this goes back to that same thing where you have to look at your individual response to this drug. If you start taking a drug and all of a sudden you start noticing, man, I'm way hungrier, I'm feeling lethargic throughout the day, or whatever it is, and you start noticing weight gain as a result of that, like, first of all, obviously, yeah, analyze your lifestyle. If you can change things and you're like, all right, actually, this is just happened to coincide with changes in my lifestyle in general, cool, maybe you can change the lifestyle things. But if it's a thing where you're like, I'm actually just ravenous all the time since taking this pill, like, obviously that's going to be hard to combat by just making lifestyle changes. Like, you're taking a drug that's clearly making you hungrier, so it's going to lead to weight gain if you follow that hunger, so you potentially have to go on a different pill, or again, discuss it with your doctor. Maybe you need to do some weight gain, maybe you've just been underweight your whole life, so this is something that you have to pay attention to the effects on your body, look at that and go, am I willing to accept these things? If you are, for the effects, like the positive effects that you want from the drug, then okay, cool, you have to accept those things. If they're not, you have other options. Again, you can discuss this with your doctor. You can look online and you can go, oh, here's one of these flowcharts of what the different pill choices would be if I have these different effects, but it is something that I would definitely just discuss with your doctor, tell them you're having different effects or side effects that you don't enjoy, and they should be able to advise you from there. I know oftentimes, this is a common experience, at least in a lot of clients that I've talked to, people will go on the pill and the only recap they ever do with their doctor is they go to their doctor every couple of months or whatever, they step on the scales and the doctor goes, yeah, okay, cool, like, you're roughly the same weight, cool, see you later, and that's the only management they ever get of their medication, because again, the pill is generally considered safe, so the doctor's not going to spend 30 minutes doing an entire like examination. However, again, you have to be the advocate for yourself. You have to go, okay, I'm having these effects, I'm experiencing these things, we've been on the pill for the last 3 months, we'll say, and I've noted these different things, I want to change, I want to go into something else. Like, you have to come to your doctor and discuss that stuff. In an ideal world, your GP would just have an abundant amount of time to be able to do a lovely medical examination every single time with every single patient, and spend 2 hours with them if they need it. But that's just not the reality of the medical system the way it is at the moment. You can obviously go into other effectively medical systems, like you can go into like concierge medicine, like you can literally pay a doctor, have them on a retainer, and if you want to be able to go in and go, oh yeah, I want an hour consult, you have the doctor on a retainer, so they're going to do the hour consult with you. But again, that's quite substantially more expensive than just going to your local GP who probably has 5 minutes to spend with you, but that is the benefit, and the whatever the negative of having effectively free healthcare in at least in European countries, a lot of European countries, with the people that we deal with, at least.
Yes, sir. And that's the pill.
Exactly. Now there are other things. Obviously, this episode we didn't cover a lot of the other contraceptive methods. Obviously, look, we're not doing a podcast on contraception. That's not what our podcast is about. But it is important to also note that beyond just the oral contraceptives, beyond just hormonal contraceptives, because you can get like intrauterine devices that are hormonal, you do still have other options. Like, you have stuff like the copper IUD, which isn't hormonally driven. For some people, they really enjoy that. They're like, this is a benefit. It doesn't sound like a pleasant experience getting it inserted, but look, if it gives you the effects that you want, happy days. But there are other options. You just need to be aware of that. You need to do your own research. You need to talk to your doctor. You need to talk to someone that you trust, as knowledgeable about this stuff, and then make a decision based on that. You might be like, look, I actually don't want to take contraceptives. I'm happy being abstinent, or I'm just going to use condoms, or whatever it is, that's again a decision that you have to make based on the results and the effects you want to get from the medication or whatever. And again, you need to consult with your doctor on this stuff. Like if he's saying you have PCOS and you need to be on the pill, like going, oh, I think I'll just use condoms instead of that for contraceptive. Like obviously that's not going to help with your PCOS management, So again, you have to be smart with this stuff. You have to self-educate, just like you do with any medication that you go on. You have to be an advocate for yourself. You have to effectively do the research yourself. Like, outsource to smarter individuals, more knowledgeable individuals. But at the end of the day, this is your body. You only have one life. So you need to make sure that what you're putting into your body and the effects that you're getting from that are conducive to the goals that you have, the lifestyle that you want to lead, et cetera, But again, there are other options which we haven't covered in this. There are also other situations in terms of, effectively where we would use exogenous hormones, right? And one of those is in regard to menopause, hormone replacement therapy in regard to menopause, right? And we'll talk about that in a future episode when we talk about menopause. But I do want you to be aware that this is one of those things that always happens. People always think of like the oral contraceptive pill. And then when they think about the typical user of the oral contraceptive pill, they think about like 18-year-olds, 20-year-olds, someone in their 20s. But you have to remember that people are still using the oral contraceptive pill up until menopause. It's not like they just go, oh yeah, actually, I'm just going to stop using that. Yeah, okay, maybe I'm married now, so it's fine. Like that's not the way it generally works. People will continually use it for their lifetime, and then the next stage that they get to, menopause, we have to discuss slightly different things in regard to that. And obviously, again, that depends on what has been going on throughout their life, because very often there's another event in between that also changes your use of exogenous hormones, and then also puts you through some pretty wild changes in terms of endogenous hormones, in terms of your own hormones, and that is pregnancy. Now, obviously, not all women are going to get pregnant, go through pregnancy. Maybe they don't want to, maybe it just wasn't on the cards for them, whatever. But it is something that a lot of women obviously engage with, deal with, whatever you want to say. So we're going to cover that next, and then we're going to get on to the menopause stuff, right? But anyway, Gary, do you have anything else to say? Anything to wrap this episode up, or just anything in general?
Yeah, so guys, if you are interested in more specific help with your training, nutrition, rehab, etc., we do have coaching spaces available. All of our coaches currently have space. So if you are interested in working with us in a training and nutrition capacity, rehab capacity, nutrition only capacity, whatever you're interested in, we can hopefully help you out. The information about that is in the description box below. And you can also just contact us on any of our social media platforms or info@triagemethod.com if you'd like more information about coaching, okay? Our social media, you can find us at Triage Method on Instagram. You'll find all of our respective coaches there. And that's the best place to follow along. If you're not on social media or you want, something into your inbox, we do have an email list, okay? We send out information to our email list, exclusive articles, things like that, updates that don't generally go on our social media. So if you want to be fully informed, then I would recommend subscribing to the email newsletter. And other than that, make sure that you share the podcast if you like it. We've been doing lots and lots and lots of female specific content now for most of this year. If you've been enjoying it, if you enjoyed this episode or any episode, leave a rating and review if you can, but at least give it a share in your story, or maybe with a friend or in a private WhatsApp group or whatever it happens to be. But we appreciate those of you who share it. We appreciate those of you who listen, and we hope that we can continue to provide you with value each week.
I have nothing else to say, so peace out.